The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and welcome to Reproaction's Act and Learn webinar for the month of May 2021. Our topic today is an important and an enlightening one. Yikes, abortion restrictions and access to fertility treatment. So your host today is myself. I'm Erin Matson. I use she, her pronouns. I am the Executive Director of Reproaction, which I co-founded with Pamela Merritt, and I am based in Washington, D.C. I am Erin to the Max on Twitter. So our agenda for today, I'll introduce Reproaction and our organization and briefly highlight fertility treatment as a reproductive justice issue, and then also where the anti-abortion movement fits in. And they shouldn't fit in at all. Unfortunately, that's not the case. And then we'll move to our panel discussion. Very excited to have the three panelists we have today. Dr. Amy Adante is an OBGYN and fellow with Physicians for Reproductive Health. Megan Jeyifo is a We Testify storyteller and is also the executive director of the Chicago Abortion Fund. And Cathy Sakimura is deputy director and family law director for the National Center for Lesbian Rights. Then we'll go to next steps and do Q&A. So a few housekeeping matters. One is if you have questions for any of the panelists, feel free to put those in the questions tab at any point. You don't have to wait until the end. We'll get to as many as we can before we close. And then also for those of you who like to live tweet, please use the hashtag Reproaction. So Reproaction leads bold, direct action to increase access to abortion and advance reproductive justice. We are deeply proud of our left flank analysis, and we're known for our willingness to hold folks on all sides of the issues we work on accountable, whether they're traditionally considered allies or opposition. And we have a deep commitment to nonviolent direct action as one of the tools in our toolbox. So I want to talk a little bit about fertility treatment and where it fits in with reproductive justice. For those who may be new to the concept of reproductive justice is not merely a replacement word for pro-choice. It is much more. Reproductive justice is a human rights framework that was developed by Black women in the 1990s concerning the right to parent, the right not to parent, and the right to raise families in safe and healthy communities. Of course, part of the right to parent on one's own terms includes access to assistance people may need to form their families as they wish. And that could include fertility treatment, that could include paid time off, that could include adoption assistance, and a whole range of options. On the topic of fertility treatment in particular, an estimated 10% of women report that they or their partners have ever received medical help to become pregnant. And I want to be clear, when I use women, I do so only if it's the data that I presented, but people of all genders can and do become pregnant, and people of all genders can and do need support with fertility treatment. Most insurance does not cover fertility treatment, and only one state, New York State, Medicaid covers any fertility treatment. No Medicaid program covers artificial insemination or in vitro fertilization. So think about that. That means that fertility treatment is out of reach for huge swaths of people. This has disproportionate impact on women of color, especially. 30% of Black women are covered by Medicaid as opposed to 26% of Latinas and 15% of white women. LGBTQ people and single people face additional barriers as definitions of what is considered infertility required for coverage of treatment when it is available from an insurer often leave them out. Transgender people are often left out of definitions of what is called iatrogenic infertility required for coverage of fertility preservation, in one example. So just to tie it up here, with fertility treatment and reproductive justice. As with abortion, the availability of fertility treatment or the theoretical fact that it exists is meaningless if it is not covered and available as an everyday part of our human right to healthcare, regardless of our identity, regardless of whether our employer has health insurance or a good health insurance plan, regardless of whether we are employed, period. Having children should not be treated as a luxury for the wealthy, and that is a true pro-life value. So let's talk a little bit about personhood and IVF or in vitro fertilization specifically. So, personhood is a hateful concept that was created by the anti abortion movement that declares full constitutional rights for fertilized eggs at the expense of constitutional rights for people with current, future, or past potential for pregnancy. Pregnancy occurs when a fertilized egg implants in the uterus. So, not only would personhood totally ban abortion, it would also outlaw common forms of contraception and fertility treatment. And again, so just to underscore this for folks who may be less steeped in this work, so by treating fertilized eggs as persons, you are treating an entity pre-pregnancy even as having full constitutional rights, which is a truly hateful concept. Um, in vitro fertilization, or IVF, is a form of fertility treatment in which eggs are extracted and fertilized in a lab before one or more embryos are implanted in the uterus. An estimated 1 to 2% of births in the US each year are a result of successful IVF procedures. And while many in what we call big pro life would like to be coy about the impact of anti abortion legislation on the ability of desiring parents to conceive, Personhood USA founder Keith Mason joins factions of the movement in being much more direct. Here's what he said to CNN once: "I do believe that declaring a preborn baby could impact IVF." And this was a narrative that, again, was out there in the last year when Amy Coney Barrett was rushed onto the Supreme Court for the purpose of overturning Roe v. Wade. That the views that she had spouted and organizations that she had worked with were also anti-IVF and anti-contraception. So I'm going to stop trying to explain medical concepts and get us with a real expert. I'm very pleased to introduce Dr. Amy Adante, who uses she, her pronouns. She completed her undergraduate degree at DePaul University and Medical School at Loyola University Stritch School of Medicine. She then completed her residency in obstetrics and gynecology at Mercy Hospital, St. Louis. During her training, she saw the harms that religious restrictions on reproductive health care can have on patients and ultimately decided to pursue additional training in abortion care. Yes. She completed her fellowship training in complex family planning as well as her master's degree in clinical science and investigation at Washington University in St. Louis. Shortly after completing her training, she welcomed her first child through assistance of in vitro fertilization. She currently lives in Chicago, where she practices as a full spectrum OBGYN. Amy, thank you so much for joining us. Amy, are you on mute? Let's see if I can help. Oh,
Can you hear me, Erin?
I can hear you. Thank you so much for joining us.
Thank you so much for having me, and thank you to everybody for joining us today to discuss two things that a lot of people wouldn't think have in common, but there is so much intersectionality between infertility and abortion. So, as you said in my bio, I spent the better part of 12 years in Catholic education through my undergrad, my residency, my medical school. And after 12 years, I was a little horrified by the way Catholic healthcare treats all things reproductive health care, not just abortion and contraception, but also infertility care as well. And that would kind of help me pivot directions to pursue formal training in abortion care, which I was very lucky to train at Washington University in St. Louis, had an amazing experience. And now I provide everything from infertility to abortion care as part of my everyday practice.
Awesome. Well, so excited to learn from you today. Thank you so much for joining us. So let's start with the facts. If you could, please describe common fertility treatments that people use to form their families, and not just what those treatments are, but how they work.
Sure. So infertility is a very common problem that a lot of people don't feel comfortable talking about in polite conversation, but the reality is 1 in 8 couples in the US will have trouble getting pregnant, and that comes out to almost 7 million people each year. The causes of infertility vary. About 30% are due to male factor, 30% due to female factor. and roughly another 30% or so that are unexplained. And so the treatment really kind of depends on where is the issue. So in order for us to have a successful pregnancy, we know that ovary has to release an egg. That egg has to travel through the fallopian tube where it'll meet a sperm, and then it has to implant in the uterus. So anywhere in that process, things can go wrong. So probably things that are, most easy to understand in terms of infertility. So male factor infertility, which means the man's sperm is either not mobile enough or there might not be enough. This can be treated with a couple different approaches. One approach is called intrauterine insemination, where the sperm is directly inserted into the uterus to try to get it closer to the egg and have better quality sperm closer to the egg. And this is a very simple treatment that is done in the office, takes about 5 minutes to do. But for more advanced cases of male factor infertility, sometimes you need to do in vitro fertilization, which, as you described, is where the egg is fertilized by a sperm in essentially a test tube, and then that fertilized egg or embryo is implanted back into the uterus. For female factor, it kind of depends on where the issue is. One thing that's really common, especially for women in the US, is something called polycystic ovarian syndrome, which is a medical condition where the ovary does not normally release an egg every month, which we know is necessary to get pregnant. And so a lot of times the treatment for PCOS, as it's abbreviated, includes giving medications to help induce ovulation. So medications that kind of give the brain and the ovary the chemical signals that they need to properly release the egg so that the sperm can reach it. And the reality is 90% of infertility can be addressed with modern science, whether it be in vitro fertilization, intrauterine insemination, ovulation induction, or some combination of those things.
Thank you so much. And wow, I had no idea that 90% of infertility can be addressed. That's really empowering to hear. Thank you for sharing that. So using fertility treatment is more common than some people might think. And I know you talked a bit about the rates of use. Who is most likely to need access to fertility treatment? And why do you think that we as a society are not talking about this more?
I think like all things reproductive health care, there's a huge stigma around infertility. I can tell you, having gone through infertility myself with my partner, it's hard to talk about. You're talking about something that is deeply personal, deeply intimate. Wanting to have a child is one of the largest decisions that I think any couple or individual can make. And so it's hard to be able to take something that can be so personal and painful and put it out in a very public way. Now, my partner and I made a very conscious decision to share with our friends and our family that we were experiencing infertility and that we were going through in vitro fertilization. And I was amazed after coming forward with my story about how many people I knew who had also had similar experiences. And it was so nice to find a community of my own friends and family who had been through in vitro fertilization to kind of have a community to go through the process with. We know that certainly people with medical conditions, so, things that I mentioned like polycystic ovarian syndrome, people who have had infections in the pelvis, like pelvic inflammatory disease, which can cause scarring of the fallopian tubes. These are people that are more likely to have difficulties getting pregnant. And we know that there are huge disparities in healthcare access, particularly for communities of color. And so, when individuals have these chronic medical problems that can't be addressed long term, this can lead to more difficulties with them getting pregnant.
Thank you for that. So at a time when we as a society need to expand access to fertility treatment and do deep work to make that access equitable so that everyone can access it, Many people are at a loss to explain how a movement that claims there is nothing better a woman can do than become a mother would turn around and prevent that same woman from using IVF to conceive a child. I'm talking about the anti-abortion movement, of course. How do you explain that?
I mean, the short answer is I can't. I think it all kind of falls under the umbrella of policing of, reproductive health care and control of other people's bodies. We hear a lot from the anti-abortion movement about this notion of personhood, which, I say this as someone that had extra embryos after my infertility treatment that are currently sitting in a freezer, and we're not really sure how many of those embryos we may use, what we might want to do with them when we feel like our family is done. And I know that is, kind of problematic for some people in the anti-abortion movement, because they truly believe that those fertilized eggs carry the same value as, somebody walking down the sidewalk. But my response to someone that does have frozen embryos is that is a very personal decision about how you feel and what value you place on those embryos. And I think each family that goes through in vitro fertilization, has to make a decision about what meaning those embryos have to them in accordance with their value system. But again, I think it comes down to something that we know is really common in the anti-abortion movement, which is controlling other people's bodies.
Thank you. That really sums it up. It is about power and control. So before moving on to the next panelist, is there anything else you'd like to share now?
I think one of the things that was just so alarming to me, having gone through the process of infertility myself as somebody who is well educated, well resourced. I was so fortunate to have an insurance plan that covered a majority of the costs of my in vitro fertilization, but it was still quite costly, quite involved, required a huge amount of health literacy. And I think, as you said in your introduction, alongside our steps to make abortion care, just and equitable and accessible to anyone who needs it, we have got to make strides in making infertility care accessible to anybody that needs it. Because as you said, for people who are experiencing infertility, the ability to become a parent should not be something that's limited to only those who can afford it.
Thank you for that. Thank you so much. And I want to encourage everyone to, if you have questions for Dr. Amy Adante, just put them in the questions tab and we'll get to as many as possible at the end. Thank you again.
Thank you, Erin.
All right, next up, our next panelist is Megan Jeyifo, who uses she, her pronouns. Megan is the executive director of the Chicago Abortion Fund, where she leads a fiercely dedicated team in providing financial, logistical, and emotional support to people seeking abortion care across the Midwest. Megan works toward a world where everyone has the resources they need to create lives, families, and communities that thrive and where a full range of reproductive choices, including abortion, are accessible and affirmed. She is a storyteller with We Testify, an organization dedicated to the leadership and representation of people who've had abortions, and speaks publicly about her experiences accessing abortion as a young person navigating parental consent laws and by plane due to clinic access. Megan is a founding member of the Studio 8 Collective, a team of creatives that believes communities thrive when all individuals have access to an ecology of culture, arts, and wellness. She is a proud mama of 6-year-old twins conceived by medicated intrauterine insemination. Megan, thank you so much for joining us today.
Thank you so much for having me. Can you hear me?
You sound great and just thrilled you're here. Let's dive right in, shall we? So the first question I have for you is, so you are a We Testify storyteller and have graciously agreed to share your story with our listeners today. I'd like to invite you to share what you'd like to share now.
Awesome. Thank you so much for having me. And thank you, Amy. It was great to hear all of that good info. And thank you for sharing about your experience with IVF as well. And I really just appreciate the opportunity to connect these two issues, both that have, helped me chart a path for my own family. And yeah, I'm a mom to twin 6-year-olds, Moni Lola and Dara. I'm very thankful we're off screen today because they've been home with me for the entire pandemic. I've also had multiple abortions and ended up conceiving my children by medicated IUI after being casually told by every doctor I spoke to on my journey to trying to become a parent that I was unlikely to be able to do so, to conceive with my own eggs. I'm really thankful for the work of everyone at We Testify, who's kind of empowered me to share my multiple stories openly and shift not just the public narrative, but my own internal dialogues about my experiences with abortion and also infertility. And so much has evolved over the years with regard to how I see my own experiences with abortion and with infertility and fertility treatments and the way we speak about them. So I'm just thankful for this platform and being asked to participate. I had my first abortion when I was 16 and my second a few years later when I was 19. The first abortion I had was later in pregnancy because, like so many, I had inadequate sex ed, also a Catholic education. Amy and I didn't know what was going on with my body or what to look for. And then it took me some time to call a clinic and get an appointment, and even more time to come up with the money and a plan to navigate the parental consent laws in my home state. I ended up having a 2-day appointment at a clinic 10 minutes from my home in Milwaukee. And on day 2, my father's partner left me there alone. And a nurse made a flippant comment that I would now call slut shaming. And I carried that offhand remark and sitting alone in that clinic with me for almost 20 years, kind of silently, until I got involved with We Testify and the work of abortion funds and started unpacking my experience and healing through the emotional support I have been providing to people seeking abortion care, first as a volunteer with CAF and now as executive director. My second abortion, even though it required me to travel by plane from Puerto Rico to from St. Thomas to Puerto Rico, where I was living at the time, was a much better experience. I knew what was happening with my body and discovered my pregnancy very early. It was just much better. As wild as having to travel was, I received really amazing care and warm care from a Metropolitan Women's Clinic in San Juan. And my abortions gave me so much. They didn't stick me with the people I had conceived with for the rest of my life. They allowed me the opportunity to continue a career path in hospitality and in the arts that has led me oddly to the land of abortion access with CAF. And they also allowed me to meet my husband of almost 15 years when I was 20, and we've now been together for 18 years. And we've built a really great life with 2 babies that I love, but our initial path to parenthood was not fun, and we were really lucky. And it was still really, really hard, our infertility journey. And we began trying to have kids when I was 29, and everyone around me was suddenly pregnant, and I wanted in on that. And we tried and tried and tried in silence. And kind of speaking to Amy's earlier point about speaking up, I wish I had done that earlier. I wish I had had conversations with people, because similarly, I learned that other folks were kind of silently enduring the same thing. And after the required year of trying, which is something most insurance companies mandate for heterosexual people before they'll help with fertility treatments, I made an appointment to get everything checked out, and was kind of really unceremoniously told that I would not be able to use my own eggs to conceive, that it was very, very unlikely. And I was really lucky to make an appointment with a specialist. We were very privileged with excellent insurance my husband had through his work. And Dr. Erica Marsh, who I will remember forever and ever at Northwestern University. I remember her the same way I remember everyone that I came into contact with at abortion clinics, because they all helped me become a parent. She was amazing, and the first person who sat me down and was like, we're gonna make you a parent, whatever it takes, we're gonna make you a parent. And again, I was just really extremely fortunate in what our insurance covered and how little I had to pay out of pocket, and having this world-class hospital available to me. And I know that is not the case for so many. And and access to fertility treatments in our country is not a right. It's an extreme privilege. We've talked, friends of mine who have also gone through either infertility or assisted reproductive technology, talked about starting a fertility fund the same way we have in abortion funds, because there is a really great need, and everyone should be able to decide whether or not to, what they want. If, as much as we should enable them to decide to not become a parent, we should also want that for everyone to become a parent. And I ended up being really lucky and conceiving on my first IUI. And it was weeks after a doctor who was both the OB and the psychiatrist who my husband and I had to see prior to being allowed to proceed with fertility treatments, told me that if my body was Vegas, she would not bet on me. And she said this at the doorway as I left her office after having listened to me sob during a mandatory hour-long counseling session. So, there were so many emotionally difficult moments and access difficult moments with both abortion and infertility. And but in the end, being able to kind of exercise my reproductive autonomy completely changed the trajectory of my life in every way. And I really want that access for all people.
Megan, thank you so much for sharing your story. And I hear the layers and the pain and the joy, and just wanted to affirm that I hear you. I would like to ask a follow-up question, because multiple things you said surprised me. You had to see a psychologist first to get, is that
Yep.
a common practice? Can you share more about that? I'm baffled. Why does that have anything to do with anything?
Yep, I believe it's common. I know it is common at the practice I was in at Northwestern, because I have other friends who have also gone to that practice. Yeah, I guess it's kind of to sort out your state, right? Your state of mind, kind of give you permission to proceed with perhaps the emotional journey you're going to experience. But it definitely felt like a hurdle. Especially because I was stigmatized in the very, I was harmed by the very person who was supposed to kind of ascertain my fitness to undergo fertility treatments. Yeah.
Oh my gosh. Just when you think that you've, like, the requirements around accessing reproductive health care couldn't get more patronizing, you learn a new one. Oh, just, well, that is a
Yeah.
good segue to my next question. So to you, so as a We Testify storyteller, you speak publicly about your abortion, and fertility treatment, as you noted, has also been part of your reproductive journey. How would you say that your stories are the same? How would you say they're different? And how would you say they're interconnected?
Such a juicy question. I mean, I think as the last 28 minutes have illustrated, accessing any kind of reproductive health care can be really difficult. And any kind of medical care really can be incredibly hard to access. And both abortion and fertility treatments are politicized and stigmatized care, or any kind of even assisted reproductive technology, not even just infertility, right? And I think we've made such strides medically in what we can achieve with both over the last couple decades, thinking about like medical abortion and the advances of IUI and IVF that have helped so many people make their own decisions about whether to start or grow a family. But both are really out of reach. There's like a commonality about financial access, and then also permission to access by the state. And anytime the state's able to restrict our ability to decide whether or not we can exercise autonomy, that's a problem. No one should be able to police our bodies. I think the stigma piece is the same, just so much. People are even myself, if you had told me 5 years ago that I would be talking about either one of these things publicly, I would have looked at you like you had, you know, multiple heads, because it's not something that I was ever comfortable discussing, even in with like my close friends. So, and I question why that is now. You know, the more that folks are able to have conversations about how we came to have the families we have, and what kind of resources we want our kids and our family members to have through our own experiences, I think will be so much better in illustrating why we need access to all of these things. And I guess how they're different, I think, you know, like a lot of people who find out that people who work on abortion access are really, really pro-family, they're kind of confused by that. And I'm always, people are shocked to hear like, oh, the majority of people who have abortions are parents, you know. So this is a family issue and an interconnected parenting issue. Yeah, did I answer all the questions? I'm sorry.
No, that's it. That you
it's so
did.
hard
That's
to speak when you can't see people's faces.
Oh yeah, it's great. It's great. And thank you so much. So my last question for you is so repeatedly anti-abortion actors have put personhood initiatives on the ballot in the states. We also have members of Congress who repeatedly introduce such legislation. These personhood initiatives would totally ban abortions, bar access to effective fertility treatments, and outlaw some forms of contraception. Ads fighting these bans often focus on access to abortion or the legality of fertility treatment, but not both. Why do you think this false binary exists of like either it's about abortion or it's about fertility treatment? And how do you think we as a movement can and should move past it?
I think I kind of touched on this in the earlier question, but I think, you know, I think treating access, again, it's about access. I think treating fertility treatments and abortion as separate is false. Reproductive justice demands that we have the right to have children just as much as we have the right to not have children. And I think really narrowing in on that message that all people who want to have children should be able to is really critical. And so much of that, as was mentioned earlier, depends on money and on who gets to have this specific type of treatments that who has the money that assisted reproductive technology demands. It's incredibly expensive, and as you said earlier, not covered by Medicaid and not covered by many insurance policies. And so I think separating those things is really false. And then again, it just goes back to stigma, right? Like we have to normalize conversations about abortion and fertility and how both make way for all kinds of families. And I know campaigns like 1 in 8 on fertility and organizations like We Testify, who have popularized Everyone Loves Someone Who's Had an Abortion, have been so helpful in normalizing these experiences and making them part of mainstream conversation, and not and allowing people to have honest conversations about what kinds of resources they were able to use to create their family is really important. I think we just have to have more honest conversations, use the word abortion, use the words assisted reproductive technology or infertility or fertility treatments, and normalize and educate people about why they're connected.
Megan, thank you so much. Is there anything else you'd like to share before I move on to our next panelist?
No, thank you so much again for having this conversation.
Thank you. Okay, so just want to encourage you all, feel free to put in any questions you have for Megan in the questions tab. We'll get to as many as possible at the end. And I'm very pleased to introduce our last panelist, Cathy Sakimura, she, her, who is Deputy Director and Family Law Director at the National Center for Lesbian Rights. She manages the day-to-day work at NCLR's departments, provides strategic support to NCLR's staff in achieving NCLR's mission and goals, and oversees NCLR's family law work. Cathy joined NCLR in 2006 as an Equal Justice Works Fellow, where she founded NCLR's Family Protection Project, which improves access to family law services for low-income LGBTQ parents and their children with a focus on increasing services to families of color. She received her JD from UC Hastings College of Law in 2006 and her BA from Stanford in 2001. Cathy is a national expert in LGBTQ family law, and in her role as Family Law Director, she works on a range of issues including parentage, custody, adoption, assisted reproduction, relationship recognition, and public benefits. She is a co-author of Lesbian, Gay, Bisexual, and Transgender Family Law, published by Thomson Reuters. In 2012, she was named one of the best LGBTQ lawyers under 40 by the National LGBTQ Bar Association. Cathy, thank you so much for joining us today.
Thank you so much for having me. Can
Thank
you hear me?
Yes, I can
Great.
hear you perfectly. So my first question for you is, we just went through your bio, and as Deputy Director and Family Law Director at National Center for Lesbian Rights, a spectacular organization, access to fertility treatment is a significant portion of your docket. Please describe your work in this area.
Absolutely. And I think it would be helpful just to sort of point out a little bit about what the problem is that's specific to LGBTQ families in accessing coverage for treatment, in addition to all of the many challenges that the other two speakers shared, which I think is really helpful for understanding the kind of personal struggles and challenges that people face in getting any kind of coverage, either being offered it and understanding what's available to you, but also having any kind of insurance or other financial assistance in accessing what is and can be very expensive treatments. And in addition to LGBTQ people who have medical infertility, of which there are some, many LGBTQ people need assisted reproductive services to conceive children, but don't have a medical condition of infertility. And I think a lot of the way that coverage for insurance and as well as the provision of services is framed as treating a medical condition of infertility, which is not how most LGBTQ people access or seek to access assisted reproduction. And so this means that to the extent that there's legislative language that requires offering or covering fertility treatments, or policy language within insurance company policies, they are often framed as covering medical conditions of infertility, either a diagnosed condition or someone unable to conceive a child after 6 or 12 months of sexual intercourse. And that, of course, if that is the standard, excludes many, many LGBTQ people who need to access fertility services to conceive, as single parents or with their partners or spouses, because they don't both have sperm and eggs and a uterus. All three of those within their relationship. And, I think that really is the core of the coverage for the cost issue that many, many LGBTQ people face. Also, I think was mentioned earlier that transgender people in seeking fertility preservation services, when they may be undergoing transition that could result in loss of sperm or eggs or uterus, don't have access to coverage for fertility preservation of freezing eggs or sperm. And so that really is a lot of our focus, is working on the legislative language and on policy language and advocating with insurance companies and employers to provide coverage that goes beyond focusing on medical conditions, to move away from only looking at either a diagnosis of infertility or the inability to conceive through sexual intercourse. I think early efforts to expand this to include LGBTQ people then said, okay, well, then you have to have 6 or 12 months of paying for your own IUI or insemination, which of course is extremely expensive and really, doesn't create parity between groups in providing services. And so really what we're moving toward is including some focus on not a condition of infertility, but the kind of just fact of the need to access assisted reproductive services to conceive.
Thank you for that. So my next question for you is, why is access to fertility treatment an issue of equity and justice? And I'm interested in both specifically for LGBTQ people and also period.
Absolutely. I think, as you shared before, that reproductive justice really is not just about the ability not to have children when you don't want to, but also the ability to have children and to have your family in a safe and supported environment. And that equity and justice has to include all aspects of what it means to have or not have children, and when to have them, and even how to have them. That if you want to have a child with your spouse, but you may not be a genetic parent, or you may not give birth because of within your relationship. There are so many different ways that people conceive children because of the combination of who they are as a family, as well as what feels right for their bodies, and that people should have access to this, and it shouldn't be cost prohibitive. So, I think both for people with infertility who are not LGBTQ, as well as LGBTQ people, lots of low-income people are completely excluded from the ability to access any kind of services for assisted reproduction. And that means that if you do have someone with a uterus who's capable of becoming pregnant within the group of people who are intended parents, you potentially could, do at-home insemination with a known donor with no medical assistance. And in fact, from our anecdotal evidence within the LGBTQ population of parents using assisted reproduction, we believe that's probably the majority of people. For some people, that's a great choice, but for other people, it feels like the only choice they have. And they end up sometimes having challenges because of that, either no screening for STIs, or also just challenges with who is a parent, whether or not the state law will recognize a donor as a donor and a parent as a parent. And that happens in part because the laws that recognize who is a parent of children is often very focused on the highest cost, most medically invasive uses of assisted reproduction. And usually, or many states, for example, require that whatever the procedure is be done by a doctor in order to be, for the donor to be recognized as a donor and not a parent, which means that many people are excluded from that kind of protection. So I think it extends from not just the ability to access assisted reproduction, but what it means to be a family and who is a parent of children who are born through assisted reproduction. That if we don't also recognize that families are created with genetic and non-genetic and birth and non-birth parents, and that people can and should be recognized as donors even if they are genetic parents, when that is the arrangement and the understanding and the reality of the child, that also is a denial of justice.
Oh, thank you so much for that. So my final question for you, it keeps coming back. We keep coming back to a common theme among all panelists about the inequity and particularly the lack of coverage. And so, just again to hammer home that the current state of access to fertility treatment is deeply inequitable and flawed today in 2021. And in many cases, it is out of reach for people except wealthy, white, heterosexual, married, and able-bodied cisgender women. So I'd love to have you just paint a picture for us and for our listeners of an ideal world where everyone is able to have children how and where they want to, and what needs to be done to assure equitable access to fertility for treatment for everyone, including LGBT people, people of color, and people with disabilities.
Thank you so much. Yes, I think that really to have a truly equitable and ideal situation for everyone, there would also need to be universal healthcare generally, because I think fertility treatments don't stop at the provision at becoming pregnant. There's lots of times people need other medical procedures. There's of course pregnancy and birth, and then the care that children need when they're born, and that there has to be some universal healthcare that really truly covers people at an affordable cost for this to really be a reality for people. And that universal healthcare should include coverage for assisted reproductive services and including surrogacy. And I'll talk in a minute a little bit about, I think, some specific things about surrogacy and what would be needed for that to be a just and equitable system. But I think it's really important that in that provision, the definition of who can access this coverage isn't limited, of course, to people who have medical conditions or requiring people to jump through unnecessary or invasive hoops. We often see this requirement like having to go to a counseling session before, accessing IVF, which is very intrusive for families, and particularly when you don't have any fertility struggles, you just literally need some assisted reproduction because you are in a same-sex relationship. It's very bizarre to have as a requirement, but really for everyone, it's very invasive and paternalistic approach to providing services. And I think really just looking at how do people really access these services and what do they really need without having a requirement that then applies to everyone that really only works for some people or doesn't work for others, to make some more of those things optional for people if it's something that they feel like they need. I think a really important aspect of this, though, is if people are using egg donors or people acting as surrogates, that those people involved in the process of assisted reproduction have rights and bodily autonomy and a need to have protection to be able to exercise those rights. And so I think people have a right to access and use those services to become pregnant, but of course, everyone involved needs protections for their health. We have very little regulation of egg donors and how they are treated from a health perspective, as well as how their needs are being met, what is the long-term effect on their health of serving as egg donors, and there's a lot more needed to protect them. And their ability to, have agency in the process and have their health and rights protected. And people acting as surrogates often don't have a lot of agency in determining how things will go for them, what their contract will be, and what their compensation will be. And because it is a large for-profit industry, I think a lot of the focus is not on that. And if there were, a focus on compensation for surrogates and egg donors less than the kind of sustaining of an industry, that would also really help with some of the things that we see that are problematic. I think probably a nonprofit system for surrogacy and egg donation is probably what makes the most sense.
Oh my goodness. Cathy, thank you so much for that. I am going to have more questions on that as time permits. That was extremely enlightening. Thank you, Cathy. I am going to move us and encourage folks to put in questions for Cathy or others in the chat. I'm going to move us along so we can just dive into Q&A. So I want to encourage everyone to plug into Reproaction campaigns. Please sign up for our email alerts at www.reproaction.org. So we host these Act and Learn webinars every month. And if you sign up for alerts, you will never miss an invitation. So please do so. And you can follow us on social media. We're Reproaction on Facebook, Twitter, and Instagram. And then please save the date for our next webinar. Topic next month is Big Pro-Life Deep Dive. Who is Operation Save America? It's going to be quite a discussion. So please join us. That'll be Thursday, June 10th at 1 p.m. Eastern. And again, if you sign up for our email list, you'll be sure to get the link. And with that, I'm going to move us to Q&A. I will start with this question that we've got in. So let's start with Cathy on this one. Are there resources or places to go for queer people trying to conceive whose insurance companies don't cover fertility treatment? Perhaps free legal resources or a list of insurance options on the marketplace that do cover fertility treatments for queer folks?
That's such a great question. We do have at NCLR a helpline that people can contact. You can do it through our website, and we also have an 800 number. Our website is nclrights.org. You can reach out to us for some more information about what may be available in your state. I think it is a really hard one because it's not just companies, but of course each individual employer's plan, what they have chosen to purchase, what's available to them to purchase, and what is the state law about requiring or not requiring coverage, and how broad is it. So each individual person has a different situation, and so that does make it hard to have a unified resource for people. So, you know, we are an impact organization, so we can't necessarily represent everybody who contacts us, but we definitely can help point you in the right direction. I would say to start with is to, you know, find out what is your plan, to talk with your employer about what is the plan and what is covered by your insurance company or by the employer itself. And there are a lot of differences in how that can be done. I did want to just briefly add that also we can talk with our employers about doing the right thing when insurance companies don't. And so, for example, at NCLR, we have long had a health reimbursement account to cover both fertility services and transition related care that is excluded by insurance or that we don't feel is adequately covered by insurance. Of course, that's a cost to the organization and the company, although not that many people necessarily are accessing it once, but it is something that employers can do to protect their employees and provide them with the care that insurance companies might make difficult or impossible.
Thank you so much.
Hey, this is Amy. I just kind of wanted to add a little bit to this insurance piece. As I said, my insurance covered my infertility services, but you know, luckily I live in a state where that is part of most insurances. But I think what I found really astounding was just truly how expensive, especially in vitro fertilization is. And even with insurance covering it, it's still, you know, you have your deductibles, and the medications for IVF cost thousands and thousands and thousands of dollars. And so, you know, I think excellent points have been made, but I really cannot emphasize enough how cost prohibitive, even with insurance coverage and fertility services, really can be for people.
Thank you for that. Megan, is there anything you'd like to add?
No, I think that highlighting the insurance issues and and the lack of supports available to people was highlighted very well.
Thank you. Okay, so I'm other folks are free to put in questions. I'm going to follow up with a question and a comment of my own because Cathy, you got me going on surrogacy, and I've actually and it brings me back to the anti-abortion movement piece of this webinar. So I've experienced firsthand to see how the anti-abortion movement has tried to use the issue of surrogacy to proclaim itself as protecting women and actually try to rebrand itself as feminist in working in coalition, preying upon even feminist groups to try to get co-sponsorships for bills that would put people in jail for initiating a surrogacy contract. And I've been extremely alarmed by that and just wanted to highlight that intersection of another mode of where this movement that is so opposed to freedom and justice and the ability of people to form families on their own terms, the insidious ways that they get involved. I'm just, I'm really excited to hear your ideas about having a nonprofit, you know, that there is a need for more policy around this field in a way that is not just simply, and we want to criminalize surrogacy, but also holding at the same time how important it is for the ability of people to form families as they wish. So it turns out I didn't really have much of a question, as more of a geek out comment, because I was just so thrilled to hear you say that. But I wanted to open up space if any of our panelists would like to share on that topic or anything else.
Hey, this is Amy. I think, the concept of surrogacy is such a beautiful thing that has helped so many people, build families. And there are certainly a laundry list of medical conditions that would, prevent a person from being able to carry their pregnancy themselves, even if, the pregnancy is a result of like their biological eggs or sperm. I was astounded to learn how many states, actually strictly prohibit surrogacy, make it illegal. And again, I think at the risk of sounding like, you know, a record on repeat, it all just comes down to, again, policing people's bodies and, kind of controlling who and when gets to become parents. But there are certainly a ton of medical conditions that, helps make surrogacy medically necessary for a lot of families out there.
Thank you for that.
I know I've talked a lot about this. I just wanted to, this is Cathy again. I just wanted to add that I think this is a really important moment for collaboration between reproductive health groups and LGBT family groups, like to talk about what surrogacy should look like, what kind of regulation should be available. I think this has been a new collaboration that I've been very fortunate to work with a number of groups in the reproductive health and rights community on advancing surrogacy regulation that protects the rights of people acting as surrogates, but also makes it possible for people to access surrogacy and for people to choose to be surrogates. And I think that is a place where, like you mentioned, where there has been a wedge put in by right-wing interests in prohibiting surrogacy and, aligning with a perspective that surrogacy is improper or anti-feminist to do surrogacy. And I think that collaboration is really important because surrogacy exists and is being used, and people acting as surrogates really do need the regulation that supports their rights and bodily autonomy.
Thank you for that. So we are out of questions. Since we do have the executive director of Chicago Abortion Fund on the line, and because funding abortion is an urgent need at all times, Megan, how can people donate to Chicago Abortion Fund if they would like to do so?
Oh, thank you so much for asking. Yeah, you can join our mailing list, sign up to become a monthly donor, or make a one-time donation at chicagooabortionfund.org. We're also on Instagram, Chicago Abortion Fund, and on Twitter at Shy Abortion Fund. And we're really interested as a fund and as a reproductive justice organization in working with other groups to affirm everybody's right to access the kind of healthcare they want or need to have children or not have children. So really thankful for being asked to participate today, and really loved hearing from all of the panelists. Thank you so much.
Thank you so much. So a special thank you to Amy, to Cathy, and Megan. I am going to end on a note from a comment we just got in the questions tab. It says, thank you so much for this webinar. So rare to see these topics presented together. I hope to see more of it. Love the mix of legal, medical, and lived experience. Thank you so much to our panelists. Have a great day. Bye.